Thank you very much, Serena, for this kind introduction. So I will speak today of the therapeutic trial. Here are my conflict of interest. So I will not discuss this year the symptomatic treatments that you use in long COVID. They are listed here for some of them, and you can notice that some of them have already proven their efficacy in trials. So do not hesitate to use, if needed, the treatment of POTS, analgesic, gabapentin, antihistaminic drug, chromoglicate, etc. I will not speak too much neither on rehabilitation and pacing, but there have been already published trials on the usefulness of pulmonary rehabilitation for hyperventilation syndrome, and also the usefulness of pacing to avoid post-exertional malaise. They have an effect. Also, it's a moderate effect and not curative. So I will speak today of the current trial for causal intervention that fights the different mechanisms that we have seen during the conference. So be aware that the trials that I will present are often pilot trials, a lack of power, the relativeness is relative, and often there is no follow-up. There is a result at the end of the trial, but no follow-up. So a few words out of the methodology. I looked on the website clinicaltrial.gov and found more than 500 studies on long COVID, among which more than 200 therapeutic trials, but only 27 trials for pharmacological and causal intervention. The rest is symptomatic treatment, physical, neuropsychological support, etc. And there is also some trials published elsewhere. So let's begin by the antiviral approach, because it is the main target. So currently there is 4 trials targeting directly the virus, using either Paxlovid for 15 days, for 25 days, Azytrelvir, and Remdesivir. So I will tell you after. So the first trial, unhappily, gave negative results, and I think that Michael will comment on this. You can see on the right that there was a slight decrease in the symptom in both groups, but there was no difference at the end of 12 weeks, and even the most bothersome symptoms was higher in the Paxlovid group. So this makes us ask ourselves a lot of questions. Why is there a failure of antiviral if we know that there is a viral reservoir? So maybe it's insufficient antiviral activity because we have, at the first generation of antiviral, a poor penetration in some reservoir, maybe inappropriate endpoint. You will see that in most of the trials that are currently done, the endpoint is either quality of life or fatigue, and very rarely biomarkers. Maybe it's also patient heterogeneity because we include long COVID without selecting, for example, the most severe patient. So, but despite this failure, I think it is really important to continue to explore the issue on antiviral activity, maybe with more potent antiviral combination, more prolonged antiviral, and of course to get valid biomarker, and maybe have collaborative effort to do very big trials. In this field also, there are the monoclonal antibody approach. You all have seen this report of 3 cases of striking rapid remission of long COVID after 1 infusion of Ronaprev, but this has not been replicated, and there is currently a trial that has just finished. Maybe also Michael will comment on this. A monoclonal antibody that is active on the first strain until Omicron BA5. Always in this field of viral inhibition, there are trials inhibiting the reactivation of other latent viruses, for example, EBV or retroviruses. And for example, temelimab, it is a monoclonal antibody that inhibits HERV-W protein, which is a retrovirus protein that is reactivated in some neurological disease such as multiple sclerosis and also long COVID. In this trial, 200 patients who had HER protein detected in the plasma received temelimab. There is also trials with HIV antivirals that are reutilized to combat reactivation of retroviruses such as Truvada, Maraviroc. There is a trial with valacyclovir with the aim to fight against EBV reactivation. And I found also a trial with lazarotin, which is an inhibitor of tight junction in order to inhibit the absorption of the virus by the digestive tract. Unhappily, again, we have negative results with the first trial, temelimab. You have probably seen recently these results. Let's move now to immunomodulatory approaches, because it's a thing really discussed as a potential mechanism. So in this field, we also have different approaches. You know, the first one was BC007, which is a monoclonal antibody directed against functional autoantibodies, directed against G protein coupled receptors. There is trial with autologous stem cells. There is trials with different cytokine, IL-1, baricitinib, rapamycin. Rapamycin, everybody speaks of that since a few weeks. It's an immunosuppressant drug, but that at low dose has not this immunosuppressive effect. It's modulatory effect, and it stimulates NK cells. And there is also Maraviroc pravastatin. I will say a few words on this last trial. So unhappily, again, don't you see that this year we have a lot of negative results, in fact. Unhappily, a few days ago, we have a negative result with BC007. So a few words on Maraviroc pravastatin, because it's quite original. You know that in COVID patients, there is an interaction between monocytes, platelet, and endothelial cells to create a prothrombotic environment. And in long COVID, the persistence of spike in monocyte has been demonstrated, and monocytes are hyperactivated, expressing CCR5 and another receptor, fractalkine. So Maraviroc is a CCR5 antagonist, and fractalkine is a fractalkine inhibitor used in this trial is atorvastatin. And in a pilot study, 18 patients received both this combination, and there was a decrease in some vascular marker, mainly VEGF and CD40L, and also a subjective improvement in some symptoms. So we decided to begin that in our department, and if you are interested, you can see a poster that we, at this Congress, showing that in patients with digestive disorder, it works, it seems to work, it seems to be interesting. And there is also a big randomized trial that will begin soon on this association. Let's move now to the neuromodulatory approaches. So what is tested? The first tested drug is naltrexone. It's an antagonist of an opioid receptor that has anti-inflammatory and immunomodulatory properties, and that is used sometimes in other conditions, a little like long COVID, for example, multiple sclerosis. So there have been two little trials, one retrospective and one prospective trial, in which there was a benefit in more than 50% of the patient with a dose, a low dose. It's not the dose that you use in drug users, but a very low dose of maximum 4.5 milligram. Our Iranian colleague also showed in a pilot study that amantadine, that is also used in chronic fatigue syndrome sometimes, can decrease fatigue at the usual dose of 100 milligram twice a day. So it's now those two approaches, you know, are tested in randomized trials. There is one randomized trial with naltrexone, 2 trials with amantadine, and also I will not comment that, a trial of statin for its anti-inflammatory effect. There are also a big list of trials that test rather a psychiatric approach with lithium, with glutamatergic modulation, with antidepressive drug, transcranial stimulation, which is given sometimes for patients very depressed. So we will have, it's quite small trials, but it's interesting to find that they are tested. So I will finish now by the approaches directed against microclots and to improve oxygenation and mitochondrial functioning. So the first approach is hyperbaric oxygen therapy. It's this time it's our Israeli colleagues that published in 2022 a trial of 73 patients which were randomized in 40 sessions of HBTO or normal oxygen. And so at the end of the last session, they observed that there was a better perfusion in brain MRI and a better cognitive function. However, it was not possible to conclude about the long-time effect. But I find this interesting. And you see that there is at least, and I think a lot of clinicians have found this interesting, and there is 5 clinical trials on these subjects in different countries. You can see in Germany, Netherlands, Canada, etc. So just look at the column of the table. It's always the same column. In the 4th column, I put always the main endpoint, and you will notice that the endpoint of those trials are really often clinical data. So a word of apheresis. What is apheresis? It is a filtration-based approach that is done to remove autoantibody, oxidated lipoprotein, large molecule, toxin, and to reduce plasma viscosity. So a lot of patients have been spontaneously to this approach and have spent a lot of money for not a lot of things. So we were really waiting for a solid study to see if this approach was functioning. So there is, for the moment, only a small study of 27 patients that were treated twice with apheresis. And after 2 cycles, it was demonstrated that there was really a reduction in cytokine, lipids, homocysteine, and the formation of rouleau with red blood cells, but there was no clinical follow-up. And a Cochrane review was made of the 5 available studies that have been begun, stating that the hypothesis that apheresis works is currently insufficient. So I don't think it's good for the patient to spend all their money for that. But happily, there are randomized trials that will evaluate this approach, because it may be useful, even if I don't think it will be an approach that will cure the treatment. Maybe it will improve for a few months, but then if we don't cut the root of long COVID, there will be a regain of symptoms. I think I arrived to the end. One of the last approach is anticoagulant therapy. So this is very interesting because we know that COVID leads to prothrombic change, and those prothrombic change, they persist in long COVID. So it was the approach of Teresa Pretorius in South Africa, in which she gave to 91 patients a triple anticoagulant therapy, dual antiplatelet therapy, clopidogrel and aspirin, and an oral anticoagulant therapy for 2 to 4 months. And after the end of treatment, she published that there was really an improvement in the symptoms and also a decrease in the microclots. So the problem to this approach is that it's really off-label. And there was 5 patients with quite serious bleeding. Not very serious, it was nose bleeding, menstruation, heavy menstruation, but it's quite complicated for us to prescribe this drug without a trial. So we are really waiting for a trial on anticoagulation therapy. So that is a very rapid overview. I am sorry, but if you need some more discussion, I will be happy to discuss with you. What can we take as take-home message? First, it is a field really rapidly evolving with a major increase in the number of trials since last year. To date, there is no conclusive success, but it is an opportunity to highlight a lot of things, and mainly the methodological needs. First, it would be nice to have a better definition of case. In those trials, it is very heterogeneous. The severity is also not given often, and the delay since the first COVID until the inclusion of the trial is not also precise. It will be nice also to have a clear homogenization of outcome. You have seen that sometimes it's fatigue score, quality of life, but there is only 1 or 2 trials for which is a biomarker. For example, for Maraviroc, it will be a biomarker, but not a lot of trial. And also, the thing that is really missing is a long-term evaluation trial, because if it's a transitory effect, it's not really interesting. So we have, since yesterday, all says that there is an urgent need for biomarkers. There are several that are developed, RNA in tissue, spike protein in plasma, cytokine profile, metabolomic profile, but no, not one of them is sufficiently specific or reproducible. So there is really a work to do together to define how to use those biomarkers. And it's crucial to multiply the trials. For me, but I don't know if you will agree, it's important to test more and more antivirals combined, anticoagulant, it seems interesting, and also to implement trial on mitochondrial dysfunction, because it's something that is really not done. And maybe to build an international consortium with clinical researchers would be interesting to better define the methodology of the clinical trials and to enlarge them to other post-infectious syndromes. Thank you very much.